So I'm Olivia Falgrak-Jones. I, since the beginning of the pandemic, have been co-chairing the Mental Health and Learning Disability Autism Cell of the Southeast region of NHS England Improvement, and the healthcare response to rough sleeping and homelessness has become part of my portfolio. We've worked really closely with colleagues across Public Health England, and they're on the call today, and the Ministry of Housing, Community and Local Governments, who are also on the call today, and we're going to hear from Lucy in a minute. In trying to I guess scope the healthcare response and then generate some discussions and ensure that there is some support to our housing leads, to ensure that there is a wraparound healthcare provision and support, which we know are critical in helping maintain successful tenancy. So what we thought we would do is get people together to have a look at some of the areas that I've managed to develop and implement a multi-agency approach in supporting people who suffer from homelessness or rough sleeping, and we're starting with Brighton and Hove today. So if I move on to Lucy, and if you would like to introduce yourself. I don't know whether Marie's on the call as well. Do you want to go to the next few slides? Nick, thank you.
Good morning, everybody. My name is Lucy Baker. I'm a rough sleeping advisor at the Ministry of Housing, Communities and Local Government. I work with a number of local authorities, both in London and across the South East, to help them address rough sleeping in their area. I'd like to give you a very warm welcome to today's webinar, which is the first in a series of webinars focusing on good practice across the health and homelessness sectors, as you've been working so closely together to protect rough sleepers and people who are at risk of rough sleeping from COVID-19. We all know that homeless people and rough sleepers in particular are disproportionately impacted by poor health, and that they often have difficulty in accessing and maintaining access to health care. And whilst COVID-19 has brought many challenges, the response to bringing everyone in has been extraordinary. At the end of March, government asked for all rough sleepers to be brought in off the streets and out of shared sleeping sites such as night shelters to protect them from COVID-19. This ask was achieved by local housing authorities quickly and at scale. To date, approximately 15,000 people who were either rough sleeping or assessed at being at risk of rough sleeping have been placed into a range of accommodation, including hotels, student halls, temporary flats and hostels. We've seen people with entrenched rough sleeping lifestyles and very complex needs access accommodation for the first time, and we've also seen how genuinely transformational this has been. By bringing people into accommodation, a golden opportunity has arisen, which is that by enabling some stability and continuity in their lives, their health needs can be finally assessed and established, and that proper healthcare can begin. As people are now starting to move on from emergency and temporary accommodation into longer-term housing, it is essential that this opportunity for access to healthcare and for it to continue is not lost. We want to build on what you've achieved so far to ensure that people are not returned to the streets and can sustain future tenancies. This work can only be achieved through strong relationships and multi-agency working. We know that the relationships between health and housing are at different stages across the South East. They are both very complicated networks. There are resource issues, challenges and gaps. And through the weekly calls on a Thursday, you've been sharing ideas to help build these relationships and networks and address those gaps. And we want these webinars to showcase the excellent collaborative work that's been achieved by health and housing working together to inspire and inform you and create a lasting legacy to improve the lives and the health outcomes for rough sleepers in the future. So thank you very much for me, and I hope you enjoy today's presentation.
Thank you very much, Lucy. Marie, is there anything else you would like to add?
No, nothing to add. Just to say that, you know, both the RSI team and the HAS team at the MHCLG are here to support you. So if there is something that you would like to discuss with us, please feel free to email us. I think most of you are email addresses. So we're here to support you. So if you see anything today or you would like to other areas of good practice, just let us know and we'll come back to you.
Thank you. So for our health colleagues, RSI stands for Rough Sleeping Initiatives and HAS is the Homeless Advice and Support Team, both part of MHCLG and supporting local housing leads in districts and boroughs and unitaries across the southeast and obviously the rest of England. So that's a good introduction. Thanks to both of you to set the scene for our colleagues in Brighton and Hove. So Emily and Tim, over to you.
Thank you. So Tim and I were asked to do a presentation just outlining how we responded in Brighton and Hove to the COVID crisis, and particularly around the joint work that was done between the local authority and our health partners. We move the slides on, please. Thank you. So I just wanted to give a bit of background to the situation with rough sleeping in Brighton and Hove, and what demand we had when the Everyone In order was issued. So Brighton and Hove consistently has high numbers of people rough sleeping in the city. And in March of this year, there were 120 people known to be rough sleeping. An additional 30 people were attending day centres and had stated that they were rough sleeping, but had not in fact been found by our street outreach team. And we had an additional 52 people in shared sleeping space accommodation, which was our no second night out service, our somewhere safe to stay service, and our night shelter. In addition to those figures, we had a predicted demand of around 103 people, and we were basing that demand on a flow to the streets of 5 people a week for 12 weeks. And that's less than half of our normal flow. Our flow does tend to decline over the winter and increase during the summer, but we had in fact seen a couple of weeks in February where flow had been as high as 20 people. And we were also expecting to get contact from probably an additional 40 people in dormitory style private accommodation, so backpackers hostels. Between March 2020 and June, we offered over 400 people accommodation in our Care and Protect services or in other accommodation procured to respond to the COVID crisis. And 280 of the people that we accommodated had been verified as rough sleeping by our street outreach team. So I just wanted to give a quick overview of services in Brighton and Hove, and these services were in place pre-pandemic. So we have a proactive, assertive outreach street outreach team, which we commission, which is run by St Mungo's. We also obviously have a housing options team, and people are often directed to the housing options team to receive advice and support around accessing housing. We have a range of off-street accommodation offers. As you can see there, both our no first night out and our no second night out services and our night shelter are all in there, and obviously none of those were available to us during this period. The normal route out of emergency accommodation and our congregate sleep space services is either into supported accommodation or into private rented accommodation. And we have a private rented access scheme, which is commissioned by the Ministry of Housing, Community and Local Government. And we do have a wide-ranging floating support offer in city to provide transition support. In addition to all of those services, we provide work and learning, we commission health services, there's peer support and navigation services. In total, we have 446 units of supported accommodation for adults, but what became very evident during this period was the high number of accommodation we have which has shared facility, by which I mean shared bathrooms or kitchen facilities. In fact, 313 of those 446 units of accommodation have shared bathroom and kitchen facilities, with an additional 20 units having just shared kitchen facilities. I think our COVID response worked particularly well, I think, in Brighton and Hove, largely because we worked absolutely collaboratively with our partners. We were very fortunate that early action enabled rapid responses. So Brighton and Hove had actually already made a decision to accommodate all rough sleepers before the Everyone In letter was issued. And we were already in the process of moving people in shared sleep space accommodation and verified rough sleepers off the street. Our housing department worked incredibly hard, and there was rapid acquisition of additional accommodation by our housing department, which made a huge difference to our ability to respond quickly. And we had very early engagement with health partners and our third sector commission services, including initial work on triaging and cohorting. And we had very early establishment of a public health-led multi-agency meeting to lead the response around the Everyone In, and around cohorting and triaging our groups. So yeah, levers and barriers, and Tim may well jump in here because I feel like I'm probably going to miss something. But I think we were very fortunate in Brighton and Hove that we had some really strong positives on our side in establishing a multi-agency response, in that we have good pre-existing relationships between Health and Adult Social Care Commissioning, which is where I'm based, with Arch, our homeless GP service, which is led by Tim, with our Sussex Community Foundation Trust colleagues, our Sussex Partnership Trust colleagues, and the Clinical Commissioning Group, including joint commissioning between the CCG and Health and Adult Social Care. We already have a lot of multi-agency responses in the homeless sector, including a multi-agency homeless health meeting, which is led by Arch, which feeds into a complex risk management meeting, which is led by a commissioned psychologist who's commissioned by Health and Adult Social Care to work particularly around issues presented to homeless people. We have the SCFT hostel nursing team who work in accommodation services and in day centres and work proactively with our street outreach team. We have a commissioned mental health homeless service working across homeless services, which provides an excellent link for vulnerably housed adults and accessing into mental health services. We also have both our outreach and our navigator service, which is a multi-agency service navigator. So it's managed by a member of staff from Mungo's that has qualified social workers, substance misuse workers, and a housing officer as part of that team. And the creation and establishment of that team has enabled really positive working relationships across all of those sectors. And our substance misuse colleagues had assertive outreach workers and workers located in the navigator team, as I've said, and have a complex case meeting weekly, which includes substance misuse services, Arch, workers from both SCFT, SPFT and wider support services. So the fact that we already had a lot of pre-existing relationships meant that it was much easier for us to establish a multi-agency response than it would have been otherwise. We've also got Pathway Plus, which provides in-reach service to acute trust settings, which is led by Arch, and health engagement workers led by Just Life and Arch. I think it's incredibly important to emphasise the very strong working relationships between individuals on those organisations, which leads into the section on shared values and ambitions. As a sector in Brighton and Hove, we have clear shared values and ambitions around ending rough sleeping, but also around working to trauma-informed models of care, which recognise the individual at the centre of our practice. And we have a collective desire to minimise the risk of harm. by having a public health and health lead for our homeless cell meeting, and the fact that that was established in MHCLG guidance was particularly helpful. It focused the response on the crisis as a public health emergency, and it removed some of the potential issues which may have been barriers to action if it had been regarded as a political issue around ending rough sleeping. By it being a public health-led issue, we were able to cut through differing citywide views on how rough sleepers should access accommodation, particularly negative ideas about readiness, deservingness, and eligibility. We had really good political support from members in Brighton and Hove, which also was incredibly helpful to us when we were establishing our work stream, and our elected member for housing sits on our homeless cell. We have really clear guidance very early on in the process, and that guidance is easy to follow. It's based on local services and it is pragmatic. It was developed by Tim, and it has been absolutely valuable to our ability to respond to the crisis effectively. It has protocols on how to assess for symptoms, how to differentiate risk levels, who to place in what type of accommodation, and how to manage infection control in settings. It was updated regularly, and it rapidly included advice on how to manage substance misuse problems, including alcohol withdrawal, how to refer to services, and how to flag up any concerns. And I think, you know, everybody involved in this, but particularly Tim, has worked really hard at managing to maintain a balance between what was ideal and what we could actually achieve. And managing risk around that has been central to our ability to respond effectively. We did have some barriers. I think, you know, you have to acknowledge what those are so that you can plan to overcome them in future. There was a culture and knowledge gap. So initially there was a gap around triaging and cohorting into accommodation, largely due to lack of knowledge and structures. And the fact that Tim was able to establish that protocol for triaging and the care of homeless persons really helped us manage that culture and knowledge gap. Accommodation availability was a significant issue, and although housing colleagues were able to rapidly obtain properties, we did have some significant concerns, particularly in the early days, that we were not going to manage to secure that accommodation, and what accommodation we did secure was really quite high cost. There was an initial pause between congregate accommodation closing and our care and protect model opening. That particularly relates, we had a weekend night shelter in place in Brighton and Hove at the point that the COVID pandemic hit, and we made a risk-based assessment to close that space, but we weren't able to offer those people accommodation immediately, which was not anywhere that we wanted to be. We also, obviously, staff numbers were quite difficult. You know, we had the impact of COVID on staffing, and we had to redeploy significant numbers of staff from other services. There were also concerns about our ability to manage infection control, and how we were best going to be able to flag up concerns. And last of all, finance was a huge issue, and still is, if I'm absolutely honest. So our response to the pandemic for the homeless sector has been very costly, and that does remain an ongoing concern. I promise I'm going to let Tim talk in a minute, by the way, don't worry, it's not all going to be me burbling at you. What we offered to get everyone in, so as I've already said, Tim devised a Brighton specific protocol for the treatment and care of homeless people. We had a care hub, and we still have a care hub in place. So that was self-contained ensuite rooms with 24-hour staffing, including medical in-reach every day from GP at Arch, from the nursing team, from substance misuse services, and by our mental health homeless team. Staffing at that service is by specialist staff from St Mungo's who've been trained by Arch around symptom checking and ensuring people's safety. In addition to that, we had 3 protect services so that we were able to effectively cohort people. So we have a multiple and complex need, high need client service, and that's particularly for those people who we know are going to struggle around self-isolating and remaining in. We have an extremely clinically vulnerable and high risk of harm from COVID service, which is where we're placing clients in those groups. And then last of all, we have a low risk of harm service, so where clients don't have a particular risk presented to them because of their health from COVID, we have separate accommodation. Everybody in all of those services is provided with 3 meals a day. Health and Adult Social Care Commissioning, we issued increased personalisation funding, not just to St Mungo's, who are running our Care and Protect service, but to all of our supported accommodation provision in the city to enable them to support people to follow guidance. So that was particularly around things like Kindles, telephones, art materials, anything that would support somebody to remain in. And we also have a peer befriending service. So we have a peer mentoring service that we commission locally, and our peer mentors went sideways and became peer befrienders, which has been really, really helpful. And having that voice of lived experience has made a real difference to some of our clients. We move on. So this is where I shut up and Tim steps in.
That's been great, Emily. Thank you so much. I'm just going to talk a little bit about the current health services we had for homeless people in Brighton. And I see, Sarah, you've asked that question already. I'm very aware, as Emily's talking, as I'm going to be talking, that we are quite unique in Brighton in terms of the scale of the problem of homelessness and also the scale of the response. So we have advantages in terms of having access to specialist services that you may well not have. But having said that, hopefully what we're talking about, and that, there are themes that we've all experienced and similar themes in terms of how we try to manage these situations. And the system that we have for homeless healthcare in Brighton has proven to be very, very good. And hopefully there are themes that you will already been implementing and that you might encourage you to explore further as well. So we have a hub and spoke model in Brighton, and we've had that for about 4 years now. And actually before that, it was developing informally, but in the last 4 years, it's been contracted as a formal way of practicing. The core part is Arch Healthcare. That's the GP surgery that I work at. I've been working as a homeless GP for 10 years now. We've been running this service as Arch Healthcare for 4 years. And that's a core primary care surgery which exists entirely for people who are homeless. So that's people who are rough sleeping or in supported accommodation, emergency accommodation, for travellers, for sofa surfers. And we have usually about 1,300 to 1,400 patients on our list, of which about 20% are female, and only 5% of them are over 65. So we're very male dominated and very under the age of 65 dominated. We're a very busy surgery. We see at least 450 different people every month. And over the course of the year, we will see at least 1,400 different people. 96% of our patients are seen on the same day that they need to be seen. And all of our prescription requests are dealt with the same day. So that the whole focus of our service is to be very accessible, to be very understanding of the specialist healthcare needs of people who are homeless, and to be set up to manage that as well as we can do. So that's the core part, that's the hub of our healthcare service. But then we have a number of spokes. And one of those spokes is our hospital in-reach service, which is also known across the country as the Pathway team. And that is led by a GP and a nurse and engagement worker who are on the wards going around finding people who are homeless, advising the admitting teams on their care and planning for their discharge. They'll see about 450 different people a year on the wards, and they liaise with housing services, with adult social care, with medics, with surgeons, to try and get people discharged safely. And what we've found is since we've had that team working in the hospital, there's been a 42% decrease in readmissions and a 32% decrease in unplanned admissions. So they've had a huge impact on how things have been working in the hospital. So that's one of our key spokes. And another of our key spokes is our health engagement team. They work very closely with our hospital in-reach team, and that's a dedicated team of health engagement workers who provide one-to-one support with over 150 different individuals a year. And their focus is really health-based, although obviously that can be quite broad at times. And In particular, they work with people who've been recently discharged from hospital to help reduce readmission, to help get them connected with local health services. And they play an absolutely crucial role in enabling discharge, preventing admission, and facilitating treatment with primary care services and secondary care services. So that's a fantastic team. It's another key spoke of our contract. A third spoke is training and citywide leadership. We do all we can to support local GPs, offer them advice, support and training when we can, talk to them about prescribing. We, as Emily mentioned, chair a fortnightly multi-agency meeting looking at the homeless women and men who we're most concerned about. We do a lot of research here. We also run an annual conference for anyone that's interested to come and learn about homeless healthcare. And that's not just targeted at clinicians, that's targeted in particular at support workers, and the understanding that they carry an awful lot of very complex situations without often the training and support that would be ideal to do so. The final spoke is clinical outreach, and that is provided by one of our GPs, and to our nurses share that as well, and that's outreach into day centres, into hostels and unsupported temporary accommodation. So very briefly, that is our hub and spoke model. That's what we had pre-existing. The huge advantage of that is that we are accessible. We're able to go and find people, but we also have a safe and trusted base where people can come to. And throughout the course of working, we've been fortunate to develop very good working relationships with a number of different services. Emily and I have known each other for years through working in this area, which meant that when this crisis hit, we were in a very good position to build on those relationships. And we already had sort of the spokes that we could work on. We were also fortunate that the CCG gave us some extra funding, because, as you can imagine, setting up these 4 different hotel sites with sort of a week or two's notice was a huge undertaking, and then providing the extra clinical support that we have done on a daily basis and being on call at weekends was also a huge undertaking. So we've had to have an extra sort of probably about 0.6 full-time working equivalent GP, and then we've put in an awful lot of hours as well. I don't want to talk too long, but that was what we had in place before, and that's what's enabled us to react pretty well following that. And if I hand back over to Emily now.
Thanks, Tim. So yeah, I mean, I think as Tim has said, we acknowledge that Brighton and Hove is very particular, and that we were very lucky to have both pre-existing relationships and very good funded services. So what we wanted to do is think about what about how we responded could apply to other areas that perhaps don't have some of the services that we're fortunate enough to have. So we wanted to think about those things that had been particularly helpful to us that could be more broadly applied. And I think, as Tim's just said, the big thing that really came out of this for us was about that development of cross-sector relationships. And anyone can do that. It doesn't take funding, it just takes time. And sometimes the willingness to put yourself in a vulnerable place and to listen openly and honestly to criticisms that partners may have or concerns that they may have. I would really, really strongly endorse the idea of establishing meetings that encourage frontline staff to work together and view each other as allies, including, the multi-agency homeless healthcare meeting, our complex risk management meeting, but also Just Life, who are part of Arch, have a frontline workers network, which is invaluable to enable people working within this sector to view themselves as colleagues. Is there any possibility that you could offer free cross-sector training? That's one way of trying to establish shared goals and shared values. Have you thought about possibly offering training in psychologically informed environment models or trauma-informed care so that everybody is working to a similar model across the system? As Tim's just mentioned, Arch run an amazing conference annually on homeless healthcare, which doesn't just work to inform people about the issues that are confronting their clients and to skill them up. It also works to bring people together and, again, establish those common goals and views. I think it's really important that you work to identify leaders, both organisationally and culturally. And that doesn't just mean people in senior positions. It can mean people who have a particular impact on the sector. You know, look to those people to steer some of that cross-sector working, to develop those joint protocols and strategies. You know, who could genuinely make that happen? That will invariably lead to improved joint working. You know, we all have the same clients in common, and we all share a goal to provide the best possible service for that group of people. So how can joint working do that? How can you establish those links with other services that will enable you to provide an effective service? And shared vision. I think it's really crucial that you are working toward a shared vision. At the moment, what I would acknowledge in Brighton and Hove is that we haven't fully established that as a citywide thing, but that we're working toward that collectively. So I'm sure that we will get there. And last of all, data. I get a bit of flack in the team because I'm a bit of a data junkie. Which is strange because I did a social research degree and always swore that I would never, ever deal in quantitative data ever again. But know your population, preferably know them by name. Understand who the people are who are homeless in your area, understand what their particular needs are, understand what their particular aspirations are, and track people's journeys. The more data you have, the better the services you can offer will be, because you will be shaping it to the particular needs of your area and the people who you are working for. And then I thought it might be helpful to have a sense of who we are working with in Brighton and Hove. So you can see from the slide there are percentages around vulnerability to COVID and people with support needs. We have significant levels of substance use and alcohol misuse within our population and really high levels of trauma. Despite really good engagement from our mental health homeless team, it can be hard to access treatment for our client group, particularly around their trauma. Substance use is a barrier to talking therapies locally, and unpicking mental health and substance use can be very hard, and it can prevent services being made available. We also have small in number but high impact cohorts with acquired brain injury, learning disability and difficulty, and autistic spectrum condition. And we struggle to provide effective services to that group. With support needs, 12% of the people we are currently working with have multiple compound needs. And by multiple compound needs, we're talking about a group of people who are going to need very, very long-term support in order to be able to sustain and maintain accommodation. And our general view is that it's that group of clients who are best served by a Housing First offer. 33% require support of some kind, ranging from transition support into private rented right up to ongoing significant support to enable them to maintain accommodation. And 37% of the people we've currently got accommodated could live independently, possibly with a little bit of transition and setup support. About 19% of the people who we are currently working with do not have a local connection to the city, and that's much lower than our previous experience. So historically in Brighton and Hove, we would see a rate of about 50% of the people we work with were locally connected and 50% weren't, but recently that has really, really shifted. Yeah, I've put a note to myself here to say, mention data again, but maybe I won't, I'll spare you. I think we also need to be really clear that we have significant levels of tri-morbidity in our population, and there are huge social stresses and insecure accommodation, which make that harder to work with. I think Arch have had over 30 patients who've died in the last 2 years, and we run a homeless mortality review process in Brighton and Hove, which so far has identified in the last, we started in April 19, and we've had 36 deaths in the last year and a wee bit, which have hit criteria for inclusion in that review process. So, you know, we are very, very aware that we must do better, and as a city we must do better. If I move on to our next steps and transition planning. So for health, Tim, please feel free to jump in. We're looking at trying to establish a care hub. So it's a long-term ambition. Tim and I can both talk for England on this particular subject. We really, really, really want to see the establishment of a care hub for the city going beyond our initial funding. So at the moment, the care hub for the city, the funding runs out in September. We think it is absolutely essential that that continues as long as there is a risk of COVID within the population. So we are exploring options to extend that symptomatic care hub for as long as we need it. We have been incredibly fortunate that Public Health have funded an infection control lead, Suzanne, who's employed by Arch, who has been phenomenal in going out to our care and protect services, but she is now auditing all of our supported accommodation provision where there are shared facilities. And as part of our transition planning within health and adult social care, we are looking at how we better embed ongoing infection control work into core contracts with our providers, and are making sure that it forms a really central part of the quality assessment framework that we review our providers against. Mental health homeless team were really lucky. Just before the pandemic, we had additional funding for mental health homeless team to enable them to work in a more assertive way. So going forward, they are going to be linking in very strongly with colleagues in street outreach services, so that we've got a really assertive engagement offer from mental health. And that is going to be incredibly important, I think, and have a real impact on our population. And primary care with Arch. So I think, as Tim's already touched on, there was some additional funding for a post based at Arch, but our demand is not declining, is it, Tim? And we need to consider, we really need to consider how we can support Arch to continue to do the work they're doing without burning everybody out. I think, essentially that's where we are with transition planning for health. With housing, our transition planning at the moment is focusing on the decant of our short life properties. So we've already lost one of our Protect hotels locally. So we had a 90-bed hotel which closed at the end of June, and we had to decant all of the occupants of that service. We were able to do that. We remodelled our symptomatic hub into a smaller building because demand had been lower than initially expected, and repurposed the 51-unit symptomatic hub into ongoing accommodation. Move on planning continues to be a really big focus of our work, and trying to identify sustainable accommodation solutions for everybody that we've accommodated. We're working with the MHCLG on remodelling our congregate models. So we're really lucky in Brighton and Hove that we have funding for a no second night out service and a somewhere safe to stay service, and both of those are being remodelled. The somewhere safe to stay service is already remodelled, and we have 17 units of accommodation with ensuite provision that we're using for somewhere safe to stay, and our no second night out service we're working to remodel now, and that will also have units of accommodation which are ensuite. As I've already said, we're embedding that infection control standard into all of our contracts going forward. And last of all, we are looking at our severe weather planning. Historically in Brighton and Hove, we have very high demand for our severe weather emergency protocol shelter. This winter, before COVID hit, we were seeing attendance of up to 40 people a night. So we are planning now for how we can safely respond to the need for severe weather emergency protocol shelter in the winter. Obviously, the letter that was released on Saturday made it clear that night shelters should not yet be opening, and our planning is assuming that that guidance will still be in place by the time we need severe weather emergency protocol shelter. Our severe weather emergency protocol shelter, we have a very low trigger in Brighton and Hove. So we have a trigger of feels like 0 or an amber weather warning. And we normally need to open as early as late September, early October. So yeah, there's quite a lot of work to do in 2 months. Recovery planning is different. We're looking at our future plans. We particularly want to increase our housing first provision. We are looking at flipping our supported accommodation model. So this was something that we were already considering as a city. And by flipping our supported accommodation model, I mean that we want to turn our large congregate hostel services into accommodation for people with lower support needs, and our smaller units of accommodation into services for people with more complex and high risk needs. That's really been crystallised for us by COVID, because what has been very clear is that the group of clients we've got who are extremely clinically vulnerable or at high risk of harm for COVID also tend to be our group of people with very high support needs. So those things are happening. What we have that is dependent on funding, so we're really interested in the possibility of a dual diagnosis rehab service. Our drug-related death meeting has flagged on more than one occasion the intersection between substance misuse and mental health, and the need for a service which can work clinically with people who are withdrawing from substances but also have mental health issues. We are looking at a combined hub of health and support services, and that is an absolute ambition for us as a city, to have services co-located. That goes back to having a shared vision about joint working and about enabling services to best meet the needs of our population. We do have really high levels of trimorbidity within our homeless population in Brighton and Hove, mental health, largely trauma, substance misuse, physical health, and all of that compounded by insecure accommodation. It has a hugely disproportionate effect on services because that group of people are really unwell and have no safe and secure base from which to operate. What we do think is if we have a combined health and support service hub, that having a one-stop shop approach, no wrong door approach, will mean that people are better able to access the support that they so badly need. And we're also looking more broadly at increasing access to housing and support. And as in a city, we have an ambition to move toward a rapid rehousing model. Tim, is there anything you wanted to come in on recovery and transition planning that I've missed?
I think you've done great. Thank you so much. I would just reinforce, I think, what everyone listening to this would agree with. I know that if you're listening to this, it's because you have an interest in the area and are probably working in it, which is that homelessness is a housing issue and it's also a health issue. It's absolutely critical, and all too often, unfortunately, the responses have been either homeless or have either been housing or they've been health, but not the both together. And that's really what we want to change. We have fantastic homeless health services in the city. We have Arch, I've talked about. We have a Sussex Community Foundation Trust outreach team comprised of nurses and occupational therapists and physios who are worth their weight in gold. We have a mental homeless team. We have a substance misuse service. And it's hard sometimes for us to work together, but we need to improve that. And then there's all the other statutory, non-statutory services as well. We're all trying to do the same thing, or look after the same people rather, in different ways. But it's very hard for us to communicate with each other, and it's even harder for our clients to communicate with all of us. So the more that we can have integrated systems where we're all working together, the more effective our working will be, and the far easier we become to access for our clients who find it incredibly difficult to work their way between all of us. So to my mind, in larger areas such as Brighton, the only answer is to have shared working spaces, shared units where we can all be working with each other, giving single offers and assessing people effectively and holistically. And in fact, I think that's an approach that can work even in smaller areas as well. And it's something that we're definitely keen to work towards, but it always comes down to money, which is frustrating given that we know that if you don't do this well, it ends up costing the council, police, health a huge amount. So we need to, I think, take a more preventative long-term approach, and that's something we've been arguing for here for a long time. So it's really important as we look to the future that the answers aren't just housing-based, but that they're health-based as well, and that housing and health start working together as effectively as possible.
Okay, and then last of all, we were asked to look at what went well and what we would do differently. I would like to tell you that we wouldn't do anything differently, but I'd be fibbing. What went well? Joint working. The fact that commissioning, housing, health partners, support services and volunteers all came together and worked together collectively was, amazing. Having a health and public health focus, as Tim has just said, really helped. It cut through barriers, it cut through political chatter, it enabled us to be really, really clear about the motivation behind what we were doing and why we were doing it. We also had really good buy-in from colleagues. CCG provided additional funding to support the Care and Protect model. There was public health funding for infection control leads. So, we worked absolutely and funded this across, the entire sector. Redeployment of staff. I cannot speak highly enough of our commissioned outreach service, our Somewhere Safe to Stay service, our navigators team and our super team, who were all St Mungos. The staff who work for all of those services have gone absolutely above and beyond and are staffing our Care and Protect service. But it is also worth saying that they're not the only people who have worked flexibly and creatively during this time. I mean, Arch, and I hope I'm not going to make Tim blush too much, but have been outstanding. They have worked well above and beyond what anyone could have expected them. They have put their personal lives and family lives almost on hold during this period in order to meet the needs of the group. So it's been brilliant. Staff's flexibility and willingness to work really hard and creatively in a really difficult environment was absolutely brilliant. What else has gone well? Massively increased engagement with health. Having GP attendance, nursing presence at all of the Care and Protect services has really enabled people to link in with healthcare. We were really lucky. We've had bloodborne virus testing taking place across the Care and Protect model, which has been fabulous. We've had health promotion, SMS have arranged needle exchange and outreach services into all of there. And our mental health homeless team have been present at all of our Care and Protect services, offering advice and support. The fact that all of the services that we commission work to a trauma-informed care model, that Arch work to a trauma-informed care model has also been invaluable. Everybody was working toward a model of offering person-centred support that minimised those sense of abandonment and loss. What we would do differently, so, the next time we have a global pandemic, I'm seriously hoping that we don't, things that we would do differently. So I think we would absolutely accept that we did not get the voice of lived experience that we should have had engaged in the strategic planning. We need to get that in place faster next time, if there is a next time. It was brilliant to have the CGL peer mentoring befriending service in place and having volunteers in the services, but we should have included them in the strategic development. The voluntary and community sector, we didn't include in strategic development as quickly as we should. I do have a regular sub-meeting with the voluntary and community sector, and that's been really positive. But again, I think, the work that they've done has been central to how we've responded, and we should have included them in earlier strategic planning. I think next time, if there is a next time, we'll introduce the role of infection control lead sooner. Suzanne's work has been transformative, but we should have had it in place from day one. And move on planning. We should have started planning our exit at the point we were planning our entry, and we didn't. It would have been good if we'd had much earlier engagement around move on planning. St Mungo's have been brilliant, but we should have been making sure that we had statutory engagement with colleagues in housing options from day one, with a physical presence at our Care and Protect service. I mean, that's been incredibly hard for options, and they have worked really well. The decant of the 90-bed hotel was an astounding piece of work, but next time we'd start doing that much earlier on. I think that's it. I was really hoping that we would have a video from one of our clients, but unfortunately St Mungo's couldn't get it to me in time, so we don't. But when we do get that, I'll circulate that to everybody.
Thank you both. This has been really inspirational. There's a few questions that we will note, and we will do a Q&A and circulate the responses. So around the contracting of the GP service, I think, data, impact evaluation, and the role that PCNs might have. So we'll take the time offline to answer and circulate, and if the video is available, that would be great. I would like to use the next 5 minutes, if possible, for Emma to describe the draft and developing transition planning, because I think one of your key points is about that joint working and that commonality of purpose, and the approach with the funding being a good thing if it's there, but sometimes a red herring. So the transition planning framework can help develop that joint partnership and multi-agency approach. So if Emma, you could come off mute and say a few words, that would be great, please.
Hi, yes, thanks, Olivia. Hi, so I'm Emma Walker. I'm a public health consultant with PHE in the South East. And with colleagues from the network, we've been developing a bit of a transition framework to support local systems and colleagues locally as you start to think about the moving on bit, and generally transition planning for the people you're working with. Essentially, it really picks up on the things that Emily was talking about in relation to the factors really that support or that are applicable across other areas and are not dependent on things like funding and stuff necessarily, and so builds on the stuff around relationships, leadership and joint working. So what we've tried to do is develop a set of principles, some of which you may recognise from the London Next Steps planning document that they produce, because we've pinched them from there, and we've also taken some of the work from the MEME transitions document, where they've got some principles within there that we've adapted as well. And so what we've tried to do is, within the transition framework, we've grouped some of the principles under 4 kind of overarching themes, one of which is around multi-agency approaches and working, one around leadership, one around voice and people experience, and one around accommodation. And within that, we've then broken that down so that people can take stock and think about where they were before COVID, where they are currently, and where they want to be in terms of an aspiration going forward. And then for each of those, we've then got, what we're trying to do is bring together examples from across the South East and elsewhere that apply to those different principles and those themes, so that you've got kind of things that you can have a look at to see how others have tackled those principles, and that you can begin to think about locally how you might approach some of those and tackle those. The directors of public health from across the South East are fully on board with this transition and framework. So what we want to do as well as part of this is to really make it something that they will use locally to influence local systems and use as a tool to kind of drive things locally, maybe in places where things aren't as far forward as they may be in Brighton and Hove, and where there might be some challenges and additional barriers that might need a little bit of a push. So that's there at the moment. We've asked for colleagues to come back to us by today with some examples to fill in around some of the case studies. The Task and Finish group is meeting again on Monday, and we're hoping to have a more final draft done within the next week or so that we'll share more widely. But if anybody wants to have a look at it that hasn't already had a look at the draft, then please do come back to us, and we're very happy to share the draft as it is at the moment. And that's probably all I'll say at the moment.
All right, thank you very much, Emma. So to flag next themes, I guess, there's a winter planning session that is planned or being thought about for the 23rd of July, again bringing together housing leads, public health leads, and we can open it up to primary care leads if they're interested. Let us know, and we'll add your names to the invitation. We also wanted to know whether this had been helpful, and whether it would be helpful to showcase other areas that might have taken a different approach from Brighton and Hove, and areas that might be at a different stage in their journey in getting together. And if you're interested in the transition framework meeting or document, again, let us know, and when it's complete, we will share the final document. So there's a couple of topics on the slide now. We're approaching past, so I'm not going to keep people much longer, but do use the chat box. Do use either Nick's email address, is leading on mental health for schemes for rough sleepers across the southeast, or the generic email address that the invitation came from, to let us know whether there are specific topics or whether you would like to showcase next time your area or the work that you are doing. So thank you very much. Thank you to Emily and Tim and Lucy and Marie and Emma for contributing to today. We will share the slides, the recording, and a Q&A afterwards. Thank you.